One of the things that really excited me about using drug-coated balloons in the coronary space was this whole idea of being able to treat lesions and not leave any metal behind. We've heard from our OUS colleagues for a long time about this concept. They've been using it, and we were really excited in the States, and it felt like every year, is this the year? And then finally this was the year, and that was really exciting for us to start seeing that idea of where we're able to treat lesions without leaving metal behind. And it wasn't just from a scientific standpoint. That was really exciting, of course, but it was also from a patient care standpoint. Patients love the idea that I can go in, treat their blockage, and not leave anything behind. So my use of the AGENT drug-coated balloon in my practice obviously started with using it in in-stent restenotic lesions. That's obviously what the study looked at, how we got our FDA approval, and that's the on-label indication. And really, it took us back to that idea of vessel prep, which is so good, for us. That's good for a variety of reasons, whether you're using AGENT or a stent or anything else. That intravascular imaging piece is so crucial, looking at good vessel prep, and then being able to utilize the balloon after all of those steps have been done. It really makes us better at PCI in general, and certainly better at utilizing this device. So one of the ways that AGENT has really affected the quality of care that we're able to give patients is that now they have options. So in certain types of patients, in-stent restenotic lesions are going to be great for this. So you're not giving them a second layer, and you're providing them a lot of options down the road. Whether down the road they may need something else, you're really, again, not taking away options, you're really adding them in this. And again, patients really like that. They like knowing that, hey, we're not going to do something that we can't undo later down the road. And that's really important. It's also really important that they know that, hey, this is decreasing the likelihood this is going to happen again. One of the challenges is anytime you instrument an in-stent restenotic lesion is the likelihood of it having a problem down the line really goes up. And being able to use AGENT to decrease that, again, without leaving anything behind, it's really important both as a clinician and for our patients. I can think of several different patients where AGENT really made a big impact. I think of the patient who had 2 layers of stent, who had already had brachytherapy to an area, who in the past we would have said, well, gosh, you've already had brachytherapy, now you have restenosis. What are we supposed to do? We know this is going to be a failing effort. But now that we have AGENT, we're able to say, hey, you know what, there's actually some pretty good data here. This is a ray of hope, whereas before you really didn't have that. And so I think that's really important. I think that there are patients who they have a stent and it's failed. And so you talk to them and you say, gosh, well, it's blocked up again. It's pretty reasonable for them to say, well, gosh, if you do it again, is this just going to happen again? Like, what does that mean for me? And to be able to say, well, actually, we have a new way of treating this where it's different. It's a different drug. It's a different mechanism. And it's a different way of treating this where we may not have the same outcome long term. That, as a patient, you can think, gosh, well, that's much more reassuring than, yeah, we're just going to do the same thing we already did. And this time, I hope it's different. So that's really impactful, both from a clinician and from a patient side. I've been really lucky in my practice to be able to get access to AGENT pretty early. And I think that for those accounts who maybe don't have access to AGENT, there's a couple things. One, you've really got to look at it from a patient care standpoint and a portfolio standpoint, right? This is a technology that very soon is going to be in most people's hands. And if you don't have it, that's going to really be a detriment to your ability to care for patients. And patients hear about this stuff. They want to know, well, hey, I heard you didn't have to use stents all the time. Is that an option? And that's going to leave you sort of behind the 8 ball in your ability to treat patients. The next piece is how do you get ready, for AGENT? And that's another big piece. And that's remembering to get familiar with your IVUS, right? Talk to your reps, get that education that you might need. Make sure you're doing the imaging. Make sure you understand vessel prep. Really work with whether it's your BSC folks, whether it's your societal agencies, whatever it is, to get that education to say, how do I need to treat this lesion in order to get ready for when I'm going to use AGENT? These are all critical steps, because just getting AGENT in doesn't mean that you know how to use it properly up front. So getting all that ready, set up, is the way to go. And then it's really talking with your administration. Say, hey, this is the next step. Regardless of what it costs or anything else, this is the next evolution in the treatment of coronary lesions. We need to get there. We're going to be behind quickly. So as we move forward with the utilization of drug-coated balloons, I've been really lucky to have a lot of friends that practice outside the U.S. And when I go and practice with them, they use drug-coated balloons all the time. And so it's been I've been really lucky to have those friendships and have that education piece to say, how do I use this? How do we pivot from just sort of the indications we have now to the future? And so It's been really fun to see, treating bifurcations, treating de novo lesions, treating left main bifurcations, all of these different types of small vessel disease, all of these different things, where it's much more common practice in many countries outside the US. Bringing those into the US and sort of seeing how it applies to our patient population, how it can utilize in all those different ways is really, really exciting. And frankly, that's the piece that I'm even more excited about. ISR is fantastic because, again, not leaving that second layer and all those things, but the potential impact is huge in terms of its ability to treat de novo bifurcations, CTOs, all those different things. So some of the sort of advancements, research in the field of drug-coated balloon therapy that I'm the most excited about would be dealing with this increasing role of how calcium sort of affects more and more of our patients as they come through. And one of the challenges with DCBs is you really don't want to dissect the vessel, right? We really want to avoid that. At least that's what we think now. And so that's certainly best practice. And so one of the things would be, how do we treat these more calcified, more difficult lesions traditionally while still being able to use a DCB? And whether that's through the use of atherectomy in various forms, intravascular lithotripsy, specialty balloons, how do we maximize utilization of that portfolio for that growing population while still being able to potentially offer them DCB as either a frontline or a secondary therapy?